All right. If at any point during our presentation you would like to ask a question, please click on the Google form link provided in the chat, and the link will also be presented during periods throughout the presentations as well for your reference. So thank you so much for joining us for our first community conversation, where we will be discussing the innovative treatment approaches that have been implemented in Calvert County to address the substance use epidemic we've been facing, both locally and across the nation. My name is Andrea McDonald-Fingland. I am the director of the Calvert County Health Department's Local Behavioral Health Authority. Tonight, my hope is that together we can break the stigma so long associated with substance use disorders and their treatment. But before I introduce our presenter, I would like to briefly share with you my own journey through stigma as a behavioral health professional. I'm a licensed social worker, and for those of you who don't know, one of the main tenets of my profession is taking a non-judgmental approach to working with clients. This is much easier said than done. I recall during my training being told by my supervisor at the time, "I don't work with addicts, they're all liars." Lacking knowledge and experience, I took this statement to heart and promised myself that I too would never work with this population. Well, a few years passed, and I was afforded the opportunity to run an intensive outpatient group treating individuals with substance use disorders, and I am forever grateful. Witnessing the transformation that occurred when someone rose from the depths of rock bottom, their life in shambles, into a state of recovery and wellness is inspiring, to say the least. Being a small part of that transformation for my clients has been one of the most rewarding experiences of my life. But my journey through stigma didn't end there. I, like many in my profession, was trained in the abstinence-only model of treatment. For those of you unfamiliar with this approach, it states that the only way to be in recovery is to be 100% sober from all substances, including prescribed medications. I often regret my ignorance in practicing this approach and the harm it may have done to my clients, showing them only one path to recovery. Since I began in my current position, I have dedicated myself to becoming educated on the best evidence-based practices to treat individuals diagnosed with substance use disorders. The Substance Abuse and Mental Health Services Administration defines wellness not as the absence of disease, illness, or stress, but as the presence of a positive purpose in life, satisfying work and play, joyful relationships, a healthy body and living environment, and happiness. I feel this defines recovery as well. Recovery will look different for everyone, and so does the path to get there. So without further ado, I have the absolute pleasure of introducing you to Dr. Drew Fuller, who will be presenting about an exciting treatment approach that reduces the risk of relapse and saves countless lives. Dr. Fuller is a board-certified addiction medicine specialist and patient safety advocate. He currently serves as the medical director of the Calvert Crisis Response Program. Thank you so much, Dr. Fuller, for being here tonight.
It's my pleasure, and it truly is an honor to be able to briefly present to you some of the things we've done at the health department and some of the other activities happening in the county. I'm going to share my screen. And does that work? Okay, and here that it does. So. Sorry, let me get this in presentation mode. So I too would like to start off with an apology, and my apology is that I'm a board certified addiction medicine physician now, but that's not my apology. My apology is for 20 years prior to that, I was an emergency physician, and for so many of those years, I didn't know what I didn't know. And I was practicing medicine, and there's so many people with substance use disorders and opiate addiction that I just wasn't able to get help because I wasn't able to really understand the disease. But once educated, that was another transformation. And what became what I thought was my more challenging patient population, ER, is my favorite patient population now. So I want to share that message with you with great humility. And what we really want to get across is that this is a disorder, and I want to focus more on opioid use disorder that is vulnerable to anyone, for kids, to moms, dads, any age, any walk of life. And unfortunately, it's far, far more common than what we thought it was. So we used to estimate that it was 1% to 2% of the population, and it's now really estimated to be about 4% to 6% of the population. And that 6% is in rural counties like Calvert and Charles and others. So there's probably 4,000 to 6,000 people in Calvert County alone that have a serious opioid use disorder. And that's the diagnosis we give. It's been getting a lot worse since the 90s, and the overdose deaths have been increasing dramatically. And now within the last 4 or 5 years, we've really been seeing them skyrocket, and that's mainly due to fentanyl, which we'll talk about in just a moment. So what does that really mean? So last year, the CDC estimates that 93,000 overdose deaths occurred. The great majority of those were from opioid overdose. And this stadium right here, I think, probably holds 70, 80,000 people. And this is an underestimate of what's really happening, because there are a lot of coroners that may not put that on the death certificate in smaller counties in various places around the country. So it's estimated that this could be 25% higher. So it's hard to imagine, but over 100,000 people in the United States are probably dying every year because of opioid use disorder. And it's now the leading cause of death for people 49 and younger, for adults, that is, but leading cause of death. And what's shocking is that such a small number of people are actually getting treatment. So it's a very common disorder, it's a medical disorder, but a small number of people are actually getting access to what's considered now the gold standard therapies that matter most. And this is of 1 in 8 people that are in treatment, and only 1 in 8 people are often being offered medications. So with the great risk here is that stigma is so pervasive, both within people that have addictions, within the community itself, and even within the healthcare providers. And so we have to address that. And so we can talk about stats all we want, but the reality is we have to keep reminding us that it's not just about a bunch of statistics. It's really about people. It's about our people here in Southern Maryland. And this is real people. It's young people, it's moms and dads that are out there, and they're dying on a regular basis, and they keep dying. And what we've done in the past simply doesn't work, and we have to radically transform our approach. And information is great, and we have to get it out there, but we have to be able to act on this information. And so in Calvert County, we've come a long way, and I'm going to tell you how we're leading the state, and we're actually leading the country, but we still have a death every 19 days on average. And it's well within this range. These were calculations from last year, but the average age was 34 years old. So these are young people. A large portion of them, we've estimated, and this is just a gross estimate, that I think around 40% or more had children. So there are a lot of opiate orphans that are being created by this epidemic. We saw this in the emergency department years ago when the grandmas were showing up as the primary caretakers because the moms and dads weren't available or weren't alive. And so the problem here is fentanyl. It's so concentrated, it's so deadly. We've all heard about it. I won't spend a lot of time talking about it, but we really do have to emphasize fentanyl is not going anywhere. It's not going anywhere because it's too profitable. A small investment on the dark web, $3,000, can be turned into $3 million profit. So they're pressing it into pills. They're selling it as Xanax and as fake Percocets. They're mixing it with cocaine. They're even mixing it with marijuana. So it would be unrealistic to think that this is just a phase, because the designer drug era is now upon us. And why does it matter? Because it's bad enough as it is. It's probably going to get worse unless we take dramatic action. So how do we kind of reboot and start taking this dramatic action? And we really have to start by rethinking our whole model of disease and what addiction is. So addiction used to be considered a moral disorder, then it was a behavioral health disorder, and it was a choice in people's lives. But really, when we look at the models, and it's not a stretch at all, but this is the reality, it's really a medical disorder of the brain. And then a lot of those behaviors that we associate with addiction are the symptoms. And people literally get taken over, and there's lots of good mechanisms to explain exactly what's happening. We can demonstrate it biochemically, we can demonstrate it structurally in the brain. But what's really important is that there are a lot of factors that contribute to addiction, biologically, psychologically, sociologically. But when the addiction happens, it really takes a life of its own. It takes its own force and takes control. And so we have to be able to take dramatic action and understand that without assigning blame. And if we really want to look at it, maybe it can be considered a pediatric developmental disorder, because so many people start using drugs of one sort or another in their pediatric or teenage years. And many of my patients started opioids. I had one today that started opioids at 12 years old. And so no one's safe from this unless we really take dramatic action. And the other thing to even take into consideration is a lot of people that have developed a opioid use disorder had a lot of trauma in their lives, or high ACEs score, or adverse childhood experiences score. And the opioids make them feel better. They blunt the trauma, they blunt the pain, they blunt the anxiety. It's not surprising at all. So the problem here is, before I even tell you that, is I try to really communicate with my audiences, whether I'm speaking to physicians, nurses, pharmacists, or other community members. And here's the metaphor, is when someone's in the depth of opioid addiction, it doesn't really matter what brought them to the edge of that river, right? Why did they fall into the water? Well, that doesn't really matter, because when they're in the river and they're running down the rapids, they're clinging on for life. And that's, what we have to do is intervene to help empower them so that they're not in that situation. And we'll talk more about that later. And then we also hear people say this, and I've even heard my colleagues say this: well, this is a choice. It's a lifestyle disease. And I said, well, okay, let's talk about lifestyle diseases. Here's one to talk about. It's 80% is due to lifestyle choices, and that's diabetes type 2. We don't go around threatening to take diabetics off their glucophage because they didn't see a dietitian or they didn't follow through with a treatment plan. And we don't tell people they can only be on their glucophage for 1 year, then they got to come off because it's a crutch. We don't say that. But the reality is, people lost weight, and and not everyone, but if losing weight and exercise could help more people come off medications, but we don't shame people because they're not able to accomplish that or haven't yet accomplished that. But for some reason in the addiction world, we shame the people for that. If we look at relapse rates from asthma and hypertension, drug addiction relapse rates are pretty similar. The problem with this chronic disorder, this chronic disease, it's so deadly. It can be up to 10% death rate per year for individuals who have experienced and survived an overdose. The chances are about 1 in 10, they'll be dead within 12 months from another overdose. And there's other things to worry about. There's addiction, suicide, and depression. There's increases in HIV, increases in hepatitis C, which is completely curable and preventable. And then we're even seeing situations where, it's preventable at opioid overdose deaths. If they're going into institutions and not being started on treatment, and then they go home, the death rate goes up pretty high from, if they're admitted to a hospital and not started on medication, the death rate increases 1,500%. Or if they're in jail and they come out and they have deprivation syndrome, and that the death rate goes up massively at large. So one of the problems is that getting people into the treatment is difficult. And so there's waits and there's delays. And because we're not treating this like it's a medical instability, we're still treating it with an old model of behavioral health, which has a role here. But if we have to look at it as a medical disorder, people are dying waiting to get into treatment. So what treatments work best? Well, we can just, tell people to pick themselves up by their bootstraps and just quit, because we know people who have done it, right? And so, yeah, people have done it, and it does work. People are able to have the fortitude and do it, but it's been shown, statistically speaking, that only works about 4% of the time. So, what about go away to rehab? Well, I try to get my patients into rehab all the time. I'm a true believer in inpatient treatment when it's combined with medications and they need it. But rehab without medications has a less than a 5% 12-month success rate. So if I was to give patients in the emergency department an antibiotic for sepsis and only work 5% of the time, what kind of doctor would I be? And then the 12 steps, which we're all big fans of. 12 steps do a bit better with alcohol use disorder, and some of the evidence is really showing that can be 35, 40% successful for alcohol use disorder. We have not yet been able to demonstrate that with opioid use disorder. And saying that it's 10% successful, that could be an exaggeration. So MAT means medically assisted therapy, and this is shown for buprenorphine is one of the 2 opioid replacement therapies. And this is about how successful it can be. Now, this graph is deceiving because I made the graph. And it's deceiving because it's not 100% successful. It's only 70% successful at best, means 70% of the population that's engaged it, or the way we've engaged it. Can we get it up to 80 or 90%? I believe we can. But we want to look at this in a relative sense and look how much more effective this is than any one of those other therapies. Are those other therapies important and good? Absolutely. But if we combine those with medications, that's the approach we have to need for success. And we have to stop stigmatizing people for needing and to be on medication. Is it all about the medications? Again, no, it's about combining it with recovery support, with psychosocial interventions and known tools that have been shown to help people. We have to rely on science and we have to rely on evidence. And so we can demonstrate where medications are successful in the brain, and we can do it where psychotherapy is successful in the brain. And the overarching goal is to bring people to a life where they're unstable, they're feeling normal again. And yet I'll tell you, I've had an addiction medicine clinic for 3 years now at the health department. The number one thing my patients tell me, and this is their own words, is I feel normal again. And it's a great feeling to see people get cars back, get their kids back, get their jobs back, and start moving forward with life. So just a few things. Big fan of counseling. Counseling definitely is definitely important, but counseling without medication has not been shown to work. And this graph shows that the line on the left was counseling without therapy, and pretty much everybody failed, and 20% of that population died. There's still dropout that happens even with medication therapy, but if you combine it with counseling, it helps. I'm not going to spend too much time going over the pharmacology, but what we would say is one of the medications used, there's 3 medications that have been approved. There's Vivitrol, which is a blocker, and there's a popular movie out about that. We have some concerns because that has not been shown to decrease the mortality or the death rate. So I highly caution people in the community and treatment providers from relying on Vivitrol for moderate to severe opioid use disorder. I'd say be very, very cautious with it because we have not shown a decrease in the death rate with it. However, the opioid replacement therapies such as methadone or buprenorphine are the ones that have shown dramatic improvements. And that graph I showed you about buprenorphine, it would show you the same thing about methadone. Methadone is very effective. It's a very old therapy that we've been doing since the 60s. It's just not necessarily for everyone, but it's still very effective. And I still refer patients to methadone centers as they need it. What we like about buprenorphine, though, is that any nurse practitioner now in Maryland or any primary physician can prescribe it, and it is highly safe and is very effective. We don't see opioid overdose deaths from buprenorphine alone. If people combine it with benzodiazepines at high doses, it's possible in other sedatives, but buprenorphine in adults, very, very safe and very effective. And then if we put this and we try to compare, like, how important is this medical treatment compared to other medical treatments? If you've had a heart attack or a stroke or a family member who has, and they're on a cholesterol agent, we've accepted that as standard therapy, right? But yet, if you've really understood that if you're on a cholesterol agent for 5 years, and by the way, I'm not suggesting anybody stop their cholesterol agents, but if you're on a cholesterol agent for 5 years and have cardiovascular disease, there's about a 4% chance that it'll prevent death, heart attack, or stroke. That seems low, but if you're on it for 10, 20, 30 years, that makes up a lot bigger difference. But I show this graph just to show you the relative importance of preventing major adverse events and medically assisted therapy, how effective it can be from preventing overdoses and other major complications like incarcerations and other things. So how important it is. It decreased the death rate in France down by 80% alone. So it works in populations. When given in emergency departments or in emergency situations, it doubles the chance that people actually will show up and stay in treatment for longer terms. And then here's the model. And I don't know if this is showing through on the slides or if the controls are coming through, but the real model has to be medical stabilization first. Think of opioid use disorder as bad asthma, and you're not going to, if someone in your family has bad asthma, you take them to the emergency department or you get them to the emergency treatment provider who treats asthma, and you stabilize them with medications first, and then you wrap around the supportive services for preventative care. That's the model that we have to switch to. That's the essential thing. We are not there yet. Calvert County is a lot further along than many others are, but from across the country, we're just not there yet. We got to get there. Medications help keep people in treatment. And there's a lot of broad benefits, 80% decrease in crime, 80% decrease in mortality, and a high recovery rate if they're in the right environment. A lot of myths and misconceptions about these medications, like they're trading one drug for another. And the reality is they're trading a life of chaos and death and high risk for stability and gold standard therapy where people can get back and feel normal and be normal again. People are just getting high off this bupe or Suboxone. So we see a lot of it with people that are using drugs. We find it on them and the police find it on them. But the reality is most people are actually just managing their disease if they're buying it off the streets, and they're doing it poorly, but it's not a great drug to get high off of. It lasts too long, and there's a high risk if you take buprenorphine, it'll cause withdrawal if you take it too closely, if you're doing fentanyl or heroin. And then people are just trying to sell it. And the fact is, if people are getting it on the streets, well, they're not dying from fentanyl. They're not dying. I mean, if they're taking buprenorphine, that means they're not taking fentanyl. And so what we do find is that if people buy it on the streets from somebody else, not only are they safer, which is a harm reduction strategy, it's not gold standard therapy, but I often find that patients will come to me and say, hey, I've been buying this. I find it's working. I'm now ready for care. So it's an opportunity to realize that this can work for them. It's so important that the National Academy of Science division of the National Academy of Medicine came out with a specific report saying it is so important that we have to have medications at every level of our treatment and of society, or every level of our treatment environments. In fact, they said to not provide medication across the entire treatment plateaus, from the hospital to the clinics to our primary care practices, is really unethical because the treatment is so effective. It's supported by a wide range of organizations. It's not a new standard of care. It's been a standard of care now for about 15, almost 20 years, and we got to really move forward with that. And then just quickly, I'll tell you what we're doing in Calvert County, and I don't want to take up too much time, but one of the reasons Calvert County is so successful is that we have a lot of crisis care and a lot of chronic care. We put them together, and now the whole community is collaborating. We're having some great successes. So here's a quick overview of the mobile crisis team, now called Calvert Crisis Response. It's a 24/7 organization or operation. It's a 3-person team. It's at the health department in Prince Frederick, and they have a mobile van as well. So they go out to people's houses. We've treated people in the woods. We've treated people in their basements. We've treated people in offices. And then we can start them and engage them and then get them hooked in with chronic care at a very short notice. It's got a licensed counselor. It's got either a nurse practitioner, or a physician on the van, or a nurse and nurse practitioner covering the van. And we can go out and meet people where they are. And basically, we're also supporting on the chronic side a treatment on demand model. People can basically come to us when they're ready, because you got to strike when the iron's hot. In the past, it used to be that they would have to call, get a number of someplace, and be scheduled out 3, 4, 5, 6 days, maybe even a week to see a counselor. And then the counselor would see them and wait for that 1-hour slot available to talk to them, and then make a referral to a medical treatment provider. That's kind of the backwards way of doing it. It's got to be medication provider first, behavioral health specialist second. That behavioral health specialist definitely should be in that formula. And we've really moved that model along. So in Calvert County, what used to take 2 weeks to get into treatment, now basically it can take 2 minutes if people will pick up the phone. And so this is not just because of the health department. This is because of, quite frankly, the sheriff's office and the state police are doing a lot of work with us in collaboration and helping people get into treatment and referring people into treatment and calling us when they know people need it or family members need it. The hospital, collaborating with the emergency department and other leaders at the hospitals, has been fantastic. So Calvert Hospital is now leading the state in actually providing treatment and linking them into long-term care. Other community partners and organizations, there's too numerous to count. CASA is one of them, but Safe Nights is another. And then even the pharmacies are now working with us so that they understand they're an important part of this treatment, of this treatment team. Because if I'm seeing someone and trying to provide them therapy and I'm writing them, and the pharmacist decides that they don't want to fill it, or they don't want to fill the prescription 2 days early, that could cause a lot of harm to a patient that needs it and is at risk for withdrawing. And so getting the word out there of what we're doing is important. At one point, we were told we were the best kept secret in Calvert County, and we're trying to change that. We used to be called Calvert the Recovery Rapid Response, but now we're Calvert Crisis Response. And we've had commercials and billboards and trying to get the word out there and trying to help to build these collaborations. And people can call 911 to reach us, so they can call an 800 number and reach our team and talk to us and get right in there if they need to. And one of the things that it's worth mentioning is that people have heard about burnout, because we're seeing a lot of burnout from various fields in healthcare because of COVID and everything else. But there's a lot of compassion fatigue, and I had it in the ER, but I had it because I didn't realize how much of an impact I can make on people's lives if I would get them into medical treatment first and then backup treatment. So our paramedics and our nurses can make a big difference, and this can help reduce compassion fatigue. And of course, no presentation now would be complete without talking about COVID, but the reality it's hit us hard. And there's many explanations for why it's hit us hard. And that's a lack of support. It's people feeling isolated, but the opioid overdose death rates around the country have skyrocketed. In fact, around the nation, the death rate went up almost 30% last year in opioids alone. Maryland, I think it was close to 20%. I need to update this slide. But Calvert County saw a decrease in 20%. And it wasn't just because we were in Southern Maryland, because, quite frankly, last year, Charles County saw an increase of 61% of deaths, and Anne Arundel County saw, I think, an increase of 20%. So we're making a big difference. And why is that? Well, we think it's a linkage of care. We think it's the police helping, it's the hospital, it's the community groups, it's the health department. Now the primary care doctors are providing this treatment. People are getting on board and getting people into, meeting them in crisis care, linking them to chronic care. And here's some updates for 2021. So we're off to a good start, but once again, these are small numbers and subject to statistical variation. But Calvert is still down. I think we had 15 deaths at this time last year, at least last reported at the last quarter, and we were down to 10 deaths at that time. Who knows if that'll actually hold out for the whole year. But for the 3-year whole, as of last year, Calvert County had the greatest decrease in the entire state. So we're leading the state, and we're now being looked to as thought leaders around the state and around the country. And it's not only the fact is it effective, it's incredibly inspiring. So the medical providers and other treatment providers are now being inspired by the difference that they can make. And it's not just about medicines, it's not just about therapy, but prevention is important. Harm reduction is important. And if we can put them all together and embrace them in a very brave way, that we're not going to be afraid of criticism or pushback, we can make a big dent and help the people. Because back to that metaphor, what's the better option for someone with opioid addiction? A life like this, which will be a short, agonizing life for them and their family, or a life like this, where they're now empowered to negotiate the hazards that are still in front of them, but they're going to do a lot better than the guy on the left. And then if we progress with this model and metaphor, it's a team effort. So it's the community providers and the community liaisons and everybody else working together to help this person navigate these hazards so that eventually they can find their own destiny. And I close by saying, again, it's really about our citizens, and it's about our young people and our moms and our dads and our brothers and sisters that are dying. And until we make a transformation, that's not going to change. Oh, was I on mute the whole time?
Thank you so much, Dr. Fuller. Just as a reminder, if anyone has any questions for Dr. Fuller or for any of our panelists, there is a link in the chat to a Google form that will allow you to input questions. Also, if you're interested in future events by the LBHA or any of our partners, you can sign up for our events email list, and we will send out flyers and brochures for local events, recovery events. All right. Okay. So next up, we are going to go to our panel. I will go ahead and introduce our panelists, and then we have some questions that we've created. And then again, if anybody in our audience has any questions as well, we'd be more than happy if you click the link and input your questions. We will relay them to our panelists and get answers for you as well. So our first panelist, Kelly Fry, is a person in long-term recovery from both mental health and substance use disorders. She is fairly new in the field and is currently working as a peer recovery specialist. Her passion is trying to help other people just like her who find themselves in a point in their life where they're capable of accepting help and connecting them to resources that can offer that help. As an individual who takes medication-assisted treatment, She can tell you from firsthand experience that it definitely saves lives because it saved hers. Next, we have Corporal Ryan Camp, who has been a deputy sheriff for 12 years and is currently a full-time special operations team leader and agency firearms coordinator for the Calvert County Sheriff's Office. In 2016, he started a collaborative program with Calvert Behavioral Health Clinic called SOLID, the Sheriff's Outreach to Loved Ones in Distress. This program was designed to make sure all victims of overdose and their families were provided with all the resources the county had to offer, along with naloxone training. This program has reached out to hundreds of victims, families, and community members. Lastly, we have Cara Herrer, who is the Director of Pharmacy at Calvert Health Medical Center. In her position, she provides a safe environment for patients, as well as demonstrates excellent leadership skills as a co-director of the Medical Center's Opioid Stewardship Committee. Cara Herrer is a, sorry, we had a little typo here. She's also a recent graduate of the leadership of Southern Maryland's executive program in 2021. And then, of course, Dr. Drew Fuller, who gave that wonderful presentation, is going to be part of our panel as well. Again, just a reminder to all audience members, please make sure you keep yourself on mute. And if you have questions, go ahead and click the link in the chat for the Google form and input your questions in there, and we'll go ahead and get started. So panelists, why do people avoid seeking substance use treatment, and what barriers do they experience? And a reminder to our panelists to raise your hand so we can unmute you if you have an answer. Dr. Fuller.
I'll just briefly restate it. They've been treated so poorly that they haven't thought they can rely on the treatment or the treatment providers is one of the reasons. There's probably many reasons, or they're just not aware of how effective the treatment is.
Kelly Fry.
I know for me, for a long time, I didn't know that there were multiple ways to recover. I was always told that if you weren't completely abstinent from all mind-altering and mood-altering substances, then you were not in recovery. So I feared seeking treatment because I wasn't sure what that even meant as far as treatment. I wasn't sure how to access the treatment, and I didn't know where to look to find those answers. So I know a lot of it obviously is related to stigma, but there are all kinds of barriers that people face when trying to access treatment. And, you know, I mean, even things as much as they don't have insurance, so they don't know if they can pay for it, or they don't have transportation to get to appointments. And so, I mean, there's just a number of different barriers.
Thanks, Kelly. Any other panelists? Ryan.
I think one of the things a lot of people deal with is from the law enforcement side, they have a lot of fear. And like you could talk about the stigma, it's something that we've gone a long way in training all of our officers, our new officers, and even our senior officers, that people can get help and to not feel like they're always going to get in trouble, and making sure that that barrier in that seeking substance of law enforcement isn't just out there to put people in jail, but also there to help.
And Ryan, are you able to talk a little bit about the Good Samaritan Law?
Yeah, so one of the things that obviously is great about that is that anybody can call in, and, you know, if you are with somebody that overdoses, not only can you not get in trouble, but even the person that is going to need that help is also not going to get in trouble. It's all about making sure those people get the proper care.
Thank you. Cara?
Hi, can you hear me?
Yes.
Andrea? Thank you. I would like to tag on to something that Kelly had mentioned about one of the barriers, and that is actually being a pharmacist, the cost of the medication of treatment. I don't want that to defer anybody from going into treatment because of the cost. Pharmacists can help you. They can help you get into programs. They can help with assistance. So I think that's really important. And actually what Dr. Fuller mentioned in his talk is really making sure there's education to the pharmacists and the community how to help. And with COVID and supply issues right now with pharmaceuticals, there's a lot of shortages of medications as well. So being able to work through that and actually helping the patient, making sure that they get their medications on time, from my perspective, is extremely important. Thank you.
Thank you, Cara. And I'm going to give a little plug really quickly. The Local Behavioral Health Authority, our organization, actually has grant funding to assist individuals who need help paying for buprenorphine medication. So if that is ever a barrier for somebody, please contact our office. We can help. We can help.
Correct. Thank you for mentioning that.
Yeah. All right. Well, we're going to move on to our next question. What is the importance of social support, such as family and friends during treatment? How critical is their involvement to recovering individuals? Kelly.
I think it's absolutely vital. I know that, again, for me, I don't like to speak on other people. So I know from my own experience, when I was in a place where I was so far into what I was doing and I had burned a lot of my bridges. And so I had lost a lot of support that I had once had. And that made it even harder for me to seek treatment because in my mind, it was like, what's the point? You know, I have no family left. I have, no friends left. You know what I mean? So having that social support is very. Can you hear me? It's very empowering to know that you have people standing behind you to help you make the right decisions in your own recovery path to be able to live a life that you deserve to live.
Absolutely. Thank you, Kelly. Any of our other panelists, the importance of social support, such as family and friends during treatment. How critical is their involvement? Dr. Fuller.
I would say, other than the patient being interested, the families are the next most important factors because they feel and see and live this disease, but it's often family members that are directing the patients to get care, or they could be stopping the patients from getting care by kind of anchoring their own beliefs to them. So if family members getting educated is incredibly important.
Thank you, Dr. Fuller. Do any of our other panelists want to answer this question, the importance of social support? All right. Well, our next question, where can you get MAT and other treatment services for substance use disorders in Calvert County? Dr. Fuller.
Yeah, what I would recommend people initially do is reach out to the health department. If they don't know of a source to do it, they can get started on treatment there, stabilized in treatment there, and then they can be referred out to their primary care providers, because we're now finding that more primary care providers are willing to provide this treatment, or at least they're getting trained in it. And the health department is not there to replace the private community. We're there to stabilize and provide services and help build up services in the community. So it's a one-stop shop here in Calvert. In fact, we're seeing people from all over Southern Maryland that are coming here. So it's a reliable way to get started.
Cara?
Hi. One thing I do want to mention is how the hospital does work in collaboration with the health department and providing MAT and services for substance use disorder. One, if someone does come directly in the emergency department, we can help get them started with MAT. And we do have the peer counselors that will come into the emergency department and our inpatient hospital to help with assistance to get them to the next level that they need to get to. So that has been a wonderful program for us. About 2 years, we started with the peer counselors in our emergency department, and also on our inpatient unit. We do provide, some medication assisted treatment in the ED, and we do make sure, as Dr. Fuller had stated, get them with a provider at the health department or some of the family practice providers. Having our opioid stewardship team and working with the county has definitely helped us with the collaboration and making sure that we can get patients help which they need.
Thanks, Cara. Any other panelists? Where can you get MAT and other treatment services for substance use disorder in Calvert County? All right, thank you, panelists. Our next question. What are your thoughts on mandating counseling in conjunction with medication-assisted treatment and or other medical treatments? Oh, why is it gonna do that? Oh, shit. Can you touch it? I have to touch the TV. Dr. Fuller.
Okay. So I have to be very careful how I say this. My wife is a counselor, and some of my close colleagues are counselors, as is the team here. Counseling is very important, and I wish more of my patients would do it. I'm a big advocate for it. Our programs are a big advocate for it. However, we have not been able to show a lot of science that demonstrated that if someone is in a very good, stable, trusting MAT relationship or medication relationship with the provider, that adding counseling on top of that has changed outcomes. Now, I believe that's probably because the studies are limited, but I would say the mandating behavioral health counseling is one of the obstacles to care, and can be fatal. And the reason I say that is that we know of programs that will not provide the medications unless people do the counseling. And it's kind of akin to, we're not going to give you your asthma inhaler because you haven't seen the person to talk about prevention and other things that can help with the other educational components of disease management that are important. So it's actually considered unethical to make the mandates now, but yet it's the common model. It's less common in Calvert, but I can tell you I'm setting up a practice in another county and it's very common there. And yet it's a barrier to care if they mandate it. If people will do it and want to do it, well, that's the better for them. Yeah.
Thanks, Dr. Fuller. Kelly?
I have to agree with Dr. Fuller. I worked at a nonprofit prior to where I'm at now, and one of their requirements for their patients to receive their prescriptions for their MAT medications is they have to do an hour-long group, either group or individual counseling session. And I know that, you know, for some people, when they're being forced to do something like that, they're not, first of all, the therapy itself isn't doing anything because they're not open to it at that time. They're, you know, if they're resistant to it and if that's not what they want to do, they're not going to gain anything from it anyway. They're just doing it more as a formality than, you know, something that they're trying to gain something from. And some people have left treatment because they refuse to do counseling because they don't feel as though counseling or therapy has worked for them in the past. And so they just quit the treatment altogether, which, as Dr. Fuller said, can be fatal.
Thanks, Kelly. Any other panelists? What are your thoughts with mandating counseling in conjunction with medication-assisted treatment or other medical treatments? Cool. Dr. Fuller.
Okay, I should state also for the record, I'm speaking on behalf as an individual here, as a physician, not on behalf of the health department. I would also state that those mandated models delay people getting the medications they need, but also reinforce the stigmatizing challenges that we have with opioid use disorder, because we don't do it for any other chronic medical disease. We don't mandate that someone see the counselor. Would people benefit from seeing the counselor? Absolutely, from many, many chronic diseases. But the fact that even our most trusted providers out there, and there's large behavioral health organizations that are operating on this model, but they're doing it because they believe in the model, that they're doing the right thing, but it's just reinforcing stigma, or it could reinforce stigma is the way I should say it.
Thank you, Dr. Fuller. And just a reminder, if you would like to ask a question of our panelists, the link to the Google form to submit your questions is in the chat box. All right, our next question. How can MAT become more well-known and used? Cara.
Hi, thank you. So I'm kind of speaking from the hospital perspective. I think from our perspective, what we have been working on this year with our opioid stewardship is really educating our providers and trying to get as many waivered. And I think just having the providers buy in and understand it, especially some of the family practice providers, and actually when they're seeing their patients on the floors, really screening them to see if they can benefit from this, working with our case management as well as working with our peer counselors. So I think from our perspective here, we're in the next 2 or 3 months really going on an education campaign at the hospital. And I think if they understand it, they understand why to use it and which patients that can definitely benefit from, we can definitely bridge the gap here at the hospital and help.
Absolutely. Thank you, Cara. And I think that your message also really generalizes to community practitioners as well, like robust screening practices, education of providers, and then education of patients in order to provide evidence-based treatment at all levels.
Absolutely. And one thing that I do also want to bring up, and we talk about chronic conditions as well. When you're admitted into the hospital, especially here at Calvert, we continue all your medications from the outpatient, and we have quite a few patients that do come in on MAT therapy, that we do have this therapy. We continue it while they're here at Calvert, which is really important. We want to bridge that gap and make sure they're continued on their home medications. I think that's sometimes the providers and the outpatient really don't understand that we're continuing that and there is no gap. And that's really important, because if they're here for another chronic condition, we're also continuing that medication from home.
Thanks, Cara. Again, panelists, our question is, how can MAT become more well-known and used? Dr. Fuller.
Getting tired of hearing from you.
Never.
What program I did not mention, but is critically important, is we have a program that's going on across the state in different counties, but once again, Calvert is truly leading the state, and this is called Hub and Spoke, where the health department and the LBHA are serving as the hub and trying to have the primary care practices and other service providers be that spoke. And so we are actively going around trying to recruit primary care doctors and educate them on the effectiveness of this treatment. We're going to counsel them through the treatment. We're going to coach them through it and build their confidence so that people can go see their primary care doctor that they have a great relationship with, and they can assume that care. And so that's going to do a lot. And other counties are trying to do it, and Calvert's already up and running. We're already doing it. We're already recruiting people. So the more that know about it, the more wins we can make.
Absolutely. And I think that that model also helps with reducing stigma, is that if I've been stable on my medication for 5 years now, and I can now go to my primary care doctor to get my meds, just like my high blood pressure, high cholesterol medication, it reduces the stigma associated with taking medication. Thank you, Dr. Fuller. Any other panelists? How can MAT become more well-known and used? All right, thank you, panelists. Next question. What are your thoughts on there being many paths to recovery? Kelly.
So I kind of spoke a little bit about this earlier in a question that we had talked about. You know, when it comes to someone's path to recovery, you can't dictate what that is going to look like for that person. If you're not living in that person's shoes, you're not walking, you know, their daily life. I mean, you wouldn't do it with the recovery of another illness. Like, you know, everyone recovers differently from surgery. Everyone recovers differently from the flu or from a cold or you know, from all these other illnesses. So why should it be okay for them to recover differently from that, but not from this? You know, as Dr. Fuller was saying, that this is a medical disease, you know, and I know that I have tried personally a few different paths to recovery, and not all of them work for me. However, I kind of created my own path by taking a little bit from each one that I tried. I took what did work for me and I continued with that, but I also continued to search for additional things to help me in my path to recovery. And thankfully, you know, going on 5 years now, I've been able to sustain this. And I really want people to know that you know, whatever pathway someone chooses for their recovery, that's okay. And it's also okay if they choose a path and that path doesn't work for them, right away. You've got to give them time to kind of figure it out, because, you know, nobody's perfect at this and people make mistakes, but eventually they will find the path, you know, that works for them, or hopefully they do, you know, as I did, because it can happen, you know, it can happen for anyone.
Thanks, Kelly. Cara.
Kelly, I just want to tag on to that and just say, you know, how supportive I see that the peer counselors are to help everyone individualized at the hospital and the impact they've made here. It's been tremendous. It's been well received. And just, I really like what you said, how everybody is individualized. And I just think your experience can help them find that way and find that path. And I just see the incredible work that your team does.
Thanks, Cara. Panelists, again, what are your thoughts on there being many paths to recovery? Any questions? Okay. Dr. Fuller.
I would just reiterate what Kelly was saying. We've seen over 500 patients, I'm sure, at the health department, and you hear it time and time again, and they had to find their own path. But we can't rule out any one option for people.
Thanks, Dr. Fuller. Okay, our next question. What community efforts can be done to help combat stigma against the disease of addiction and medical treatments for that disease? Kelly.
I would say doing things such as this, having community forums, places where people can listen in and kind of educate themselves, having whether it be formal or informal trainings, just getting that education piece out there so that people know more about it. And that way they're less likely to continue with the stigma that is associated with it. Yeah, I mean, I just think education and just having people who, you know, I'm a big believer in, you know, the whole peer revolution, and that people who are doing well as a result of, you know, utilizing MAT services, showing that it can work, and that, you know, they can go on to be these productive members of society that everybody always talks about, and showing that, I mean, you know, a lot of people, if they didn't know that I personally was a person who was on MAT, a lot of people are like, oh, I never knew that, unless I self-disclosed to them. And I disclosed to them for a reason, because I want them to see that, you know, people who are on MAT, you know, you never know what that could look like for someone. So just educating and letting people see the successes of it. And people, you know, people who are on MAT still are facing stigma, even if they are doing well. And a lot of times they personally don't want to disclose, just because even though they're doing well, they don't want the backlash from it.
Thanks, Kelly. Ryan.
Just to kind of steal a little bit from Dr. Fuller, but he talks about normal. And I think the more we are in the community and we are normalizing that this is a disease and that there is plenty of help out there and that people aren't struggling alone, we as, you know, law enforcement, it's taken, especially Calvert County, it's taken us years to actually get that training, to get it out to all of our agency, but also to the public, of that it's an event, it's here, this is something that we have to do, and it's a normal thing, and like Kelly said, the more we can get it out there, the fair, is going on right now. If we can get people a booth at the fair, I don't know if Dr. Fuller, you guys have your guys there now, but just having it in the public so people can see is definitely a way to combat that stigma.
Thank you, Ryan. Again, panelists, what community efforts can be done to help combat the stigma against the disease and medical treatments? Cara.
Thank you. I do think our community does come together well. Just from a collaboration standpoint with everybody right now who's on the panel, who is also on the call. And I definitely think making sure that we're all on the same page and kind of sending one message and, helping them. And I do like what Ryan said about being visible at the fair and being visible in more places that it is normal and they can have help, and we are there to help as a community and help combat the stigma that they have, and what medical treatments are also available.
Thank you, Cara. Any other additions? What community efforts can be done to help combat stigma against the disease of addiction and medical treatments? All right, we'll move on to our next question. Some people say that addiction is a disease and others believe it is a choice. What do you think and why? This should be a good one. Kelly.
I definitely believe that it is a disease. I know that it is a disease because I know myself when I was using and myself now are like Jekyll and Hyde. I'm two completely different people. And it's because when I was actively using, I was so encompassed in just everything that came along with that my every waking moment revolved around nothing but that. I had no time, no room left to think about or worry about anything but that. And as hard as it is for me to admit, but that includes my family, my children, my own welfare, my hygiene, for Christ's sake, just anything. It literally just completely takes you over. And I know that even though I'm the same person, that was then and now, but it's even hard for me to believe that that was me back then, that I could do the things that I did and that I could make the choices that I made at that time. But you don't have a choice. Once you're already using there, you don't have a choice, unless you're getting treatment, there is no choice.
Thank you, Kelly. Dr. Fuller.
Yeah, I don't think I could say it any better than what Kelly just said. I would just emphasize that the most thoughtful researchers in the world that are looking on this are showing very clear behavioral pathways that just essentially get taken over. And I would implore people to consider, look how hard it is to change any habit. Even something as simple as I'm addicted to the news on my phone and I've been telling myself for a year to stop. letting it consume me. And something as simple as that consumes me. And so, and that's nothing compared to the addictive nature of tobacco, of opioids, of cocaine and stimulants. It's nothing compared to those. And I find it's hard to stop. And so I would implore people to, that was something that we would say many, many, many years ago. And it's just unfortunate when it does get brought up, but we have to have a thoughtful and engaging discussion when it does get brought up.
Absolutely. Thank you, Dr. Fuller. Any other panelists? Some people say addiction is a disease and others believe it's a choice. What do you think and why? Dr. Fuller.
I have nothing to say about this. I don't want to keep hammering home the point, but I mean, choice is a relative thing, and when people get consumed by this, I would say again, let's look at the metaphors. Let's look at the obvious examples that we see around us. I mean, why would a mother ignore their child? There's something deep and internal when they get on this addiction that it just takes them over. And then when they get into treatment, you see a massive reversal in many people's lives. And so choice is a relative term that we should be very careful with.
Thank you, Dr. Fuller. And I would like to acknowledge someone in our chat. My 2 cents, I think we need to treat it as a disease. Dr. Fuller did a great job of comparing it with other chronic diseases. Any other panelists have any input on whether or not addiction is a disease or a choice? All right. So to add on to that question, how do you believe counseling support groups, medication-assisted treatment, and other treatments can help a person who struggles with addiction? Dr. Fuller.
I mean, I would love to hear from you from that standpoint, because I would just briefly share that while I am a proponent of medical therapy, it helps contain and stabilize and allows people to start rebuilding their lives, but people would do a lot better job and if they were supported through constructive evidence-based means and supportive environments with counseling and other things. So.
Absolutely. And as a social worker, I've worked in the field of behavioral health for over a decade now. I actually worked as a therapist for the majority of that time. And the one thing that I noted is, and you mentioned this in your presentation, Dr. Fuller, that it may even be a pediatric disease or disorder, that addiction, it may start when you pick up drugs for the first time, but that a lot of the times there is underlying trauma that has occurred prior to the addiction fully forming. And there are estimates that up to 85% of individuals with a substance use disorder have some sort of trauma that occurred prior to that addiction. And so whether it be a sexual assault, whether it be the loss of a parent at a young age, whether it be the divorce of your parents, you talk about ACEs or adverse childhood experiences, that there are studies that have been duplicated and replicated numerous times showing that the higher your ACEs score is, the more likely you are to inject drugs, the more likely you are to use substances and multiple substances. It even impacts physical health. The more likely you are to have chronic obstructive pulmonary disorder or COPD, that the impact of childhood trauma on the lifespan is enormous. And so while, Dr. Fuller discussed the importance of medical stabilization, that the root cause of why substance use occurred in the first place doesn't get treated by starting on a medication, and that those feelings can start to bubble back up once sober, because if you're using in order to numb yourself, if you're using in order to run away from uncomfortable feeling or even intolerable feelings, that will still occur once the use of substances ceases. And so I think that that's one of the reasons why counseling can be such an important tool along with medication-assisted treatment, is that the reasons that you started using in the first place are still going to be there even when you stop using. And I think that Kelly has really talked a lot about why peer support is so important, but one of the things that I've always heard from everybody that I treat is you can't recover in a bubble. You don't recover in isolation. That recovery communities can just be such valuable resources. Having people alongside you who have been where you've been and who have traveled similar paths to yours can just be such a valuable asset throughout your journey and your path to recovery. So that the combination of treatment modalities, the combination of peer support, all of that put together gives you your greatest likelihood of success. So anyway, that would be my clinical opinion. Thanks, Dr. Fuller, for asking. All right, let's go to Kelly.
So just to kind of add on to what you were just saying a little bit, Andrea, and a part of what Dr. Fuller had shared in his presentation, when he was showing, how successful different things are, such as, like 12-step fellowships. And I think that's why they are partially as successful as they are, even though it's not as successful as medication. But I think that forming bits and pieces of the concepts behind 12-step fellowships, along with medication and with therapy. I mean, there's so many different components to recovery, but just the fact that you have other people who have lived experience just like yours, there to support you and encourage you along your path is very critical. And it's very helpful knowing that you're not alone. And then, in comes the isolation piece. You're not isolated. You're not alone. There are other people out there like you. And so I think that's, partially why 12-step fellowships do have a little better success rate, and if we could have 12-step fellowships or some of the, just some of the components of that along with the medication, and then have therapy, and, it would just, you're completely setting yourself up for success.
Absolutely. Thank you, Kelly. Another component that I could add, I'll try not to get on too many soapboxes here, is that there's a lot of theories behind addiction also being caused by a real lack of connection. I was in a training recently that discussed the drastic increase in overdose deaths and opiate use over the past, I'd say, decade or so. And they asked everybody in the training, does everybody know what happened about a decade ago? And nobody could think of it. And she said, is the rise of social media. Not only did social media make access to substances a lot more abundant, because you didn't have to drive into the city to get drugs, you could just find them right there online. But that social media has also really decreased the quality of a lot of social interactions that we have. And there have been studies showing that social media can lead to increases in anxiety and depression. And so one of the things that peer support provides is true connection with another person, as well as increasing the quality of the interactions or potentially increasing the quality of interactions that you're having with other people. Humans are social beings. We come from tribes, if you look back throughout history, and we do really need each other in our lives, with maybe some exceptions. and that living in a society that doesn't really cater to rich and robust social connection can actually be a huge detriment. So peer support really just helps to deal with that aspect of addiction, the isolation, and the ability to just really have somebody who's there and who understands you. All right. So I'll redirect back to the rest of our panelists. Did anybody else have any thoughts about how you believe counseling, support groups, MAT, and other treatments can help a person who struggles with addiction? All right, we'll move on to our next question. How does stigma play a part in preventing individuals from receiving appropriate treatment? Dr. Fuller.
I'm certainly no social scientist, but just based on what my patients have told me and what I've observed is that, people, once again, it's fear. How often do we not do something because of fear? And the patients, if they feel stigma from loved ones, from society, from treatment providers, they're going to be fearful or reluctant to actually, get that treatment. And then when stigma also is, once again, when it's so pervasive, it hits so many different parts of our treatment society, but even our addiction treatment professionals are subject to stigma, not only from their jobs, but even they're vulnerable to stigmatizing people, even the way they classify these disorders and treat patients. So I'm trying to become more sensitive and compassionate myself, and I'm trying to teach that to my colleagues as well.
Thank you, Dr. Fuller. Cara.
I think one of the things that I see here is people or individuals will feel that they'll be treated differently if they're going into some type of treatment, or that somebody may shun them, because their friends or, their family don't understand what, treatment is and how it can help them. And it kind of ties into the question of it's really important that you still, we went into the beginning talking about making sure your family and have support from your friends during that treatment. And I think listening to someone is also really important, and having your ears out there and listening to what they're saying and how they need help, and how you can help someone as well. And making them understand that this is the right step for treatment.
Thank you, Cara. We have another comment in the chat. Somebody said, for those struggling, fear of losing a job may be a factor. Stigma in the workplace can be a factor. Kelly.
So there's stigma associated with a lot, and it's not just treatment as a whole, but it's also different levels of treatment and different kinds of treatment. And there's outside stigma, and then there's, the stigma that even people who are receiving the treatment that they kind of place on themselves almost. They feel like if they don't go inpatient and they decide to do an outpatient MAT therapy, then, they're going to be looked at differently because they didn't do it one way, or, vice versa. So when I first started my recovery journey, I thought that the only way that you could recover, you had to go inpatient treatment, and, it was just this set thing, and that's how it was. And that was it. And so when I tried MAT therapy a few years back, I thought that I was doing it wrong. And I kind of had placed that stigma on myself because it's what I had heard from other people. So, people can internalize the stigma that, even if somebody's not shaming them directly, but they see other people being shamed, and then they carry that same shame with them. And so whether it be because of fear, like Dr. Fuller was saying, or shame and guilt, I think, you know, fear is probably one of the biggest ones. And I would have to say that right below fear is shame, whether it's people shaming you or you shaming yourself.
Thank you, Kelly. Do any of our other panelists want to answer? How does stigma play a part in preventing individuals from receiving appropriate treatment? All right, we'll move on to our next question. What changes need to be made in the addiction treatment sector to increase the success rates in individuals with substance use disorders? Kelly.
I feel like you guys are going to get tired of hearing me now. I would have to say making sure that aside from being medically stable, but just having their basic needs met. A lot of people who are dealing with substance use, they are homeless or they are, you know, without support. And so having someone be able to just have something as basic as a safe place to lay their head at night is crucial, because it's hard for them to even comprehend anything beyond that, because they spend their entire day worrying about where they're going to sleep that night, where are they going to keep their belongings, you know, where am I going to take a shower, where am I going to get something to eat today. So ensuring that they have just basic needs met is, I think, super important.
Thank you, Kelly. Dr.
Kelly, that was so well said, and I think very underappreciated. I think there needs to be a transformational approach to the way we educate not only the community, but the treatment community, because we in healthcare, and I use healthcare as a very broad sense, are very slow to change. It takes decades, but we don't have decades. But we really need to start with understanding the science and the best evidence and being dedicated and committed to that. And then throwing out the models that just don't work and haven't worked, or modifying them in a way that really work better. In fact, I would quote this, the Surgeon General report a few years back said that addiction treatments that are abstinence-based only are scientifically unfounded. And so we just have to understand that and move forward with it. And then in addition to that, I think we all need greater cultural sensitivity training, greater understanding of trauma and how to handle it, and then just a greater understanding of how do we increase our tolerance. I mean, I have patients that, end up relapsing, and then, they don't feel like they can come back. And I'm like, no, let's come back, and this is not the second chance program. It's a third chance, fourth chance, fifth chance. It's the infinite number of chances program, if that's what they need. But, we have to do it within, appropriate standards. But I think it's all of those things: science, compassion, understanding, and intolerance.
Thank you, Dr. Fuller. Any other thoughts from our panelists? What changes need to be made in the addiction treatment sector to increase the success rates in individuals with substance use disorders? Or what about in other sectors? So we don't even necessarily have to talk about just the addiction treatment sector, but we have panelists that are from other sectors within our community. What other types of changes do we need at a community level, at a hospital level, even at the sheriff's office? What could we do differently that would increase success rates for individuals with substance use disorders? Cara.
From the hospital's perspective, like I mentioned before, is having more availability to having access to what's needed to help individuals with substance use disorders, having the support from our social work and case management, our behavioral health unit at the hospital, the peer counselors, also access to MAT treatment, not just to wait till you're discharged to the hospital, but to have it available when you're ready for it. And if you would want to start now, to bridge that gap between the hospital and also going out into the community when they're discharged. So I think it will become more successful for us to help with that. And I will tell you, during COVID, there was a gap where we didn't have any visitors in the hospital. We didn't have anyone here, and the peer counselors were trying to do their work, just not being in the hospital. We were able last year in the fall to integrate the peer counselors back into the hospital, which has been a huge satisfier. And I do know that, I believe in June or July of this month, we had 12 inpatient visits, which has increased tremendously. And just letting everybody know, providing that information to our staff that the peer counselors are available, will definitely help increase the success rates from our hospital and my perspective.
Thank you, Cara. Ryan.
As the sheriff's office, one of our biggest things is always training and knowledge. We're always trying to push out to all of our officers as much knowledge that we possibly can get. And from us, it's the resources from everybody on this panel. All of us have worked very well together over the years, and pushing out as much of this information to all of our officers so they know what they're dealing with when it comes to the community itself. And not only that, but being able to have those resources available. So when they are asked by the citizens in the county of what can I do or where can I go, they already know, they already have the connections, they have the packets available to give out to the community.
Thank you, Ryan. I think everyone answered that question. So we'll move on to our last question. So again, just a reminder, if you have questions for our panelists, please go ahead and click the link in the chat to our Google form. You can also sign up for our email list to get information about future events via that link. Alrighty, panelists, last question. What efforts have been made in Calvert County to help individuals with substance use disorders the residents may not be aware of? Kelly.
Again, I think I would have to kind of go back to the whole peer movement. I know when I tell people that I'm a peer recovery specialist, they kind of look at me, like I have two heads. And so I have to kind of explain to them what that is. And so them just finding out that there are people who are out working in the community in a professional role, who are, out there to help others who are going through similar situations, and just knowing that we are out there and we're growing. The peer field is growing and it's expanding, and we are moving into all different types of professional roles while still being a peer specialist, but also doing, specializing in different fields as a peer specialist. So I think, now that we are growing as much as we are, and we're really getting out there and putting ourselves out in the community and just kind of openly talking to them about, where we came from and where we are now, and just allowing them to see the transformation themselves is really key.
And Kelly, can you talk a little bit specifically about the PATH program for all of our attendees?
Absolutely. So I work at the LBHA and I do the PATH program. So it's Projects for the Assistance in Transitioning from Homelessness. And what I do is I am a peer recovery specialist, and I work in the community with individuals who are either experiencing homelessness or who are at imminent risk of becoming homeless, and who have a serious mental illness. I try to connect them to resources. I try to make sure that they're getting coordination of care, making sure that they, again, kind of going back to that basic needs. If there are just basic things that they need, making sure that they have them until we're able to hopefully get them into a program or find them housing, or get them stable somewhere, making sure, that they have a tent or a sleeping bag. I do a lot of outreach. I just try to work with them, find out what it is that they want, and then really work on those things. Obviously housing would definitely be a number one thing, but we all know that, housing is a bit of a challenge in Calvert County right now. So trying to see if they'd be willing to even relocate, and working with other community organizations outside of Calvert to try to place people to where they do have their basic needs met, such as having a safe place to lay their head at night.
Thanks, Kelly. All right. Any other panelists? What efforts have been made in Calvert County to help individuals with substance use disorders that residents may not be aware of? Dr. Fuller.
And again, this group has heard this, but it's the 877 number for the Calvert crisis response. It's a one-stop call to at least enter into the system and to start getting stabilized. And it's 24/7. And I still don't think enough people know about it. We should have a big, I wish we had more money to have more billboards and put up posters. But if there are opportunities for the community to get involved and put up the window decals and to help promote it, especially in areas of high traffic, foot traffic, it could do a lot.
Absolutely. And Dr. Fuller, if you could, would you put the number in the chat for us?
Yes.
Thank you so much. Any other panelists? What other resources are available for individuals with substance use disorders in our county? Kelly.
So it's not so much individual resources as much as it is, I don't think the community realizes how much of a collaborative effort is currently going on within the community, with all different organizations and, such as law enforcement and the hospital and the health department and physicians and pharmacies, and just, all of these people coming together collectively to try and work on things for the community, for the greater good of the community.
Absolutely. Thank you, Kelly. Ryan.
I definitely want to agree with Kelly on that. I think all of us here, we all have each other's information and we all have each other's resources, and the community needs to know that maybe one of us can't help in one way, but somebody else can, and we know that we're able to reach out to each other. And that's what the community needs to know and be able to see.
And Ryan, I'm going to put you on the spot. Is there any information you can share with us about the drug court and the detention centers services?
I can't offer too much on that. I could definitely get you in contact with more. I do know that, especially with our detention center, that they are providing services, also not only resources, but giving naloxone to everybody, giving training, reaching out to the families. And like I said, I can obviously get you guys more information if needed.
Thank you so much, Ryan. Cara, I saw your hand go up.
Yeah, thank you. I kind of got frozen for a little bit. I was
I
was trying to answer before. Everybody had excellent points and brought out, and exactly what Ryan said, how we all work together. But, two things, when a patient comes into our emergency department, if they do overdose or we feel that they're higher risk, we do send them home with a Narcan kit. And we work in collaboration with the health department to provide those Narcan kits. Another thing from the hospital is when they do come into the ER, we will make that call to the peer counselor right away, and they will do the best to come and see the patient or the family or anyone with the substance use disorder that does need help. I mean, just coming to the ER. I mean, we don't want to overload our ER, but if they need help and they come to our ER, we will get them the help they need and direct them the best way that we can to get that help.
Thank you, Cara. Any other resources our panelists would like to share about? All right, so just a reminder, anybody who has any questions, feel free to click the link in the chat for the Google form, and you can input your questions there. While you're doing that, I just want to let everybody know that in Calvert County, we have a number of licensed facilities that provide services from as low intensity as early intervention or DUI, DWI intervention, all the way up to inpatient or residential substance use services. If you or anyone you know is ever in need of any services, you can always call the Calvert Crisis Response hotline, or you can even contact our office. We have brochures printed out that has information about all of the clinical resources here in the county for substance use treatment. CASA also has the Hope for Calvert website, which has a lot of resources on it as well. And Candy, if you want to go ahead and put the Hope for Calvert link in the chat, that would be fantastic. It is a resource guide for substance use resources that includes treatment. It includes 12-step programs and other self-help meetings. And so, you know, there are a lot of options when it comes to treatment. There are options up north, down south, here, a lot here in Prince Frederick. So there's always somewhere to go. And many of our local providers actually will provide transportation to treatment services. All right, so we're at the end of our questions. If anybody who doesn't have access to the chat has a question, please feel free to unmute yourself, and now's the time to speak up and go ahead and ask questions of our panelists. Also, as a reminder, the link in the chat to our form for questions also includes a spot where you can put an email address if you would like to receive information about upcoming events, both from the LBHA and any of our community partners. You can type your email address into that field and we will put you on our email list. I will try not to blast you too often. I am sometimes guilty of that, but I will be very discerning when it comes to utilizing this email group that I'll be creating. Again, it'll be for any events, recovery events, mental health, substance use, anything going on in the community for individuals who may be interested in learning more or finding out about resources. All right, well, before I let everybody go, I just want to thank all of our presenters and panelists. We could not have done this without you. Thank you so much for your insight and input into our topic tonight. I'd also like to thank Katie Wandishin and Sierra Ringley, both who are LBHA employees, for helping with planning and moderating this event. I'd like to thank Calvert Health Medical Center, the Calvert County Health Department's Behavioral Health Clinic, the Calvert County Sheriff's Office, and Candy D'Agostino with the Calvert Alliance Against Substance Use. Thank you guys so much for all of your assistance with this event, the planning, the logistics. just for everything. You've all been invaluable. Thank you so much. And thank you to our audience members for coming. We really appreciate you guys as well for looking out and trying to educate yourself and find out more about what's going on in Calvert County. And we would hope that you would pass all of this information along to anybody who'll let you, who'll listen. All right, everybody, take care. Have a great night. Thank you so much.
Thank you.
Thank you.